Welcome. I'm Cynthia Stewin, and I'm pleased to be your chair of the NGO Committee on Aging. And I'm especially pleased that we're a co-sponsored session today with the NGO Committee on Mental Health, of which Holly Shaw is chair, and she'll be with us and speaking today. And also pleased that Kiran Rabheru can be with us today. They'll both be properly introduced when we get to that segment of the program. Boy, it's been a busy couple of months. Thinking of March, when the Commission on Status of Women met, and I felt watching many of the parallel and side events that there was much more content this year on older persons. And our own subcommittee on older women did a fabulous job of organizing a parallel event on older women and climate change, as well as several other of our NGOs in our membership who organized parallel events, IAGG, IMPEA, ILC, and others. So let's hope we're making some inroads there. In April, another one of our newsletters came out, and I hope you are reading them cover to cover. They are packed full of so much information. The April issue was on the theme of sustainable development in older persons, and certainly also conveying important messages as we prepared for the open-ended working group, April 11 to 14. I'm not going to steal any thunder from Frances when she gives her report next on that, but it's looking hopeful. But this year also, the World Summit on Information Systems, WISIS, right? World Summit on Information, WISIS, much easier to say, is this week holding its special track on digital technologies and older persons. I was honored to be part of the opening panel on Monday morning of this week for this whole special week, where there are anywhere from 1 to 3 special 1-hour sessions devoted to whether it be AI, any and all of the digital space, and older persons. And I know we put it in the newsletter, but you must save also May 17th, which is World Telecommunications and Information Society Day. And the theme is Digital Technologies for Older Persons and Healthy Aging. So do be sure that you register for that online. Also, UNICE, the UN Economic Commission for Europe, one of the 5 regional commissions, of which North America is part with Europe and parts of Asia, is holding the 4th appraisal of MIPA in Rome, Italy, and that takes place June 16 to 18. And I've been invited and will attend the ministerial meeting on aging during that time in June in Rome. So lucky me. Also, I have just heard, and I believe it's accurate, that the World Elder Abuse Awareness Day will take place in Rome on the 15th, World Elder Abuse Awareness Day. So that would be live. I don't know whether that will have a webinar online component available to you. However, it's 9 a.m. in Italy, which would be rather early here in the States for you to watch. But anyway, stay tuned for more information on that. And then lastly, of course, the high-level political forum is coming up July 5 to 15 in New York at the UN, which is now open for business and in person. So anyway, we'll hope that, and the stakeholder group on aging, Erica chairing, has already been extremely active in preparing and groups of people and members of our own committee have participated in preparation of the position paper and making nominations for speakers for the high-level political forum. So anyway, maybe there'll be time at the end if there are any questions or comments about that, or you can put it in the chat. But now let me turn it over to Frances, who not only is our vice chair, but also co-chair of the subcommittee on human rights of older persons, to debrief with us and tell us next steps on the open-ended working group on aging. Frances?
Good, thank you, Cynthia. As you all know, the main goal of the NGO Committee on Aging is to support efforts of the NGO community and member states to get an international legal instrument to protect the rights of older persons. And I just want to quickly remind everybody and call attention to everybody about what the international legal instruments did for women's rights, children's rights, and persons of disabilities rights. So here we all are working very hard to try and get a convention, international legal instrument for the rights of older persons. And so the last meeting, the most recent meeting, was held from 11 to 14 April, and many of us attended in person at the UN. Under pressure from NGOs around the world to move the process forward before 2024, when the last two issues will be discussed, and pressure from a few member states, the open-ended working group supported Argentina's proposal to establish a cross-regional core group to work on a decision that will be presented to the next session of the open-ended working group in 2023 for member states to establish an intersessional working group to determine the main gaps that are currently in the international human rights system for older persons, which would be the basis for further negotiations of instruments and measures to close those gaps. I mean, it's only at the UN that you would have a meeting that would convene another meeting in order to establish a further meeting in order to report back to the first meeting. But we are now waiting to hear about the status of this cross-regional core group. So, and we'd like you all to watch our notifications and also our website to find out more as more information comes along. But in the meantime, I want to also draw everyone's attention that in response to the Human Rights Council in Geneva, its resolution 48/3, the Office of the High Commissioner for Human Rights will be organizing a multi-stakeholder meeting in July to discuss the Office of High Commissioner's report on normative standards and obligations under international law in relation to the promotion and protection of human rights of older persons. And at that meeting, it's a 2-day meeting, it will submit its conclusions to the Human Rights Council, and in order to see how we can push the process forward in New York. So the basic argument that we're using is that older persons should be viewed from the perspective of human rights as a human rights issue and not just an issue of medical rehabilitation and social welfare. So please join us in advocating for this, and you will get more information in the next few days, actually, on the website to update everybody on what is happening in the area of human rights. Thank you. So I will turn the floor to Erica.
Thank you, Frances. Thank you, Cynthia. May is Older Americans Month in the United States. I'm very pleased to be moderating this conversation on mental health for the NGO Committee on Aging. And we have two extremely well positioned experts to talk to us on this topic. Holly Shaw is a professor, a clinician, consultant, and advocate focusing on global health and healing. She is a graduate of the Harvard Medical School Master Class in Global Health and has the Master's Certificate Program in Global Mental Health, Trauma and Recovery. Her graduate work was achieved at Adelphi University, and her undergrad was at Boston University. Please bear with me because the bios are kind of long, but I think it's important for you to hear their bios so you know where they're coming from to be able to ask some really substantive questions. Holly's work within the UN system represents the International Council of Nurses and includes civil society leadership, serving in appointed and elected positions in DGC and ECOSOC. Hope everybody knows those acronyms. So I'm not going to get into them. Somebody can write about them in the chat. A former director of the Global Executive Committee and member of several substantive committees, Dr. Shaw is on the steering committee of the Working Group on Education for Global Citizenship and currently serves as Chair, NGO Committee on Mental Health and Chair, NGO Committee on Education, Learning and Literacy. She is the president of the US Board of Directors of the Akshara Foundation, an innovative world-changing educational system in Assam, India. Dr. Shaw is a frequent speaker at many UN global civil society conferences and has served as a moderator at the DPI DGC briefings and programs, including the 2020 World Health Day event, celebrating the work of nurses and midwives, reminding world leaders of the critical role they play in keeping the world and its population healthy. She's contributed to and developed CSW parallel events and programs since 2008. She is also the author of several peer-reviewed journal articles and chapters, and I'm not going to get into all of that. And we can post Holly's bio on the in the chat. So I now, before I don't want to introduce Kiran right now, I want to have Holly kick us off with her presentation, and then I will come back to tell you all about our lovely Kiran Rabheru. So over to you, Holly.
Thank you very much. It's such a pleasure to be here. And we're also celebrating this month Mental Health Awareness Month. So this is really fitting. And my presentation is going to be a little bit different in that I am, by the way, a nurse, not a physician, not an MD. And my focus and approach is a little bit different. So I'm going to be talking about mental health, not psychiatric issues. And I've decided to try to do it from an SDG perspective, which took hours, but I think, and I'm hoping will be satisfying for all of you. So I'm always challenged at this point when it comes to sharing my screen. Can we move ahead and give us a moment to do that, or do you think we can do that?
All right, while we sort out the tech, and I'm terribly sorry everybody who's on the call, I'm going to move on to Kiran. So it is my honor and pleasure to introduce to you all Dr. Kiran Rabheru, who is the chair of the Global Alliance on the Rights of Older Persons, GAROP. Dr. Kiran Rabheru is a full professor of psychiatry. Oh my gosh, I cannot say the word all of a sudden, of psychiatry at the University of Ottawa. He is certified as a subspecialist in geriatric psychiatry. Currently at the Ottawa Hospital, he serves as medical director of the geriatric psychiatry program, electroconvulsive ECT program, as well as the behavioral support team. Dr. Rabheru has passionately served older persons throughout his career. He has served as president of the Canadian Academy of Geriatric Psychiatry and a board member of the Canadian Psychiatric Association. Dr. Rabheru currently serves as the co-leader of the Canadian Coalition of Seniors Mental Health and board director of the International Longevity Center. Dr. Rabheru obtained his MD at UWO in 1980. He became certified in family medicine in 1987 and obtained his fellowship in the College of Family Physicians of Canada in 2004. Dr. Rabheru is a founder of the RCPSC, subspecialty of geriatric psychiatry in Canada, and is a recipient of the Outstanding Achievements in Geriatric Psychiatry in Canada Award. So, Kiran, the floor is yours.
Thank you very much, Erica. And I really appreciate the very kind introduction. I often say, you know, sometimes the talk is inversely proportional to the length of the introduction, but I hope that's not the case here. So with that in mind, I'm just honored and privileged to be here today. And thank you to all of you for including me in this wonderful presentation. So understanding the human mind, I was just reading about this. The mind is its own place and in itself can make a hell of heaven or a heaven of hell, according to John Hamilton. So I just wanted to start with that because it is the one thing that helps us think, feel, and behave the way we do. No other organ in the body does that. And so, according to many different organizations, there is no health without mental health. These are both indispensable human rights and are prerequisite to living one's life with dignity. Unfortunately, mental health systems have been in crisis, with the burden of mental illness being among the 10 leading healthcare-related issues worldwide, with no measurable reduction in such for over 30 years. At the same time, we have a demographic time bomb that's ticking. Today's 703 million people who are 65 years of age or older is going to be 1.5 billion by the year 2050. Now, of these, 20% will have some serious mental health condition, most commonly depression, dementia, anxiety, and substance use disorders. And these are very often complicated by other factors such as physical illness, psychosocial and environmental factors, all culminating in significant disability for some of those older people. And these ominous trends have been accelerated by the COVID-19 pandemic, with widespread increases in brain health challenges. But let's get one thing straight. Older people per se are not a homogeneous group. Most are relatively well physically, mentally, they're financially secure, they engage and contribute to our society, they vote, they pay taxes, and they're not a burden on society. So I want to start with that. However, ageism affects every single older person. We're all at risk of discrimination, with ageism being at its root. And it can be interpersonal, institutional, or self-directed. And the last one is the most difficult one, I think, to deal with. Ageism frequently intersects with other implicit biases, which have, by the way, become much more explicit during the COVID-19 pandemic. And the two that I'm going to talk most about are mentalism, or biases against people with mental health conditions, and the prejudice against people with disabilities or ableism, especially because mental health issues are silent disabilities, invisible disabilities. These biases are the root cause of the poor quality of life and premature deaths we see in millions of older people, particularly during the COVID-19 pandemic. compounded by major gaps in legislation, policies, and practices. These biases render the central transformative promise of the UN's 2030 agenda to leave no one behind a very elusive goal. Well-known and evidence-based interventions to prevent or to reduce the risk of the burden of mental health conditions are not accessible to people, older people, due to the political determinants of health. All the governments and policymakers in this world should be culpable and responsible because they do not allow the integration into public health and social policy to promote good mental health and to prevent and prevention as well as the treatment of mental illness. This requires adopting and implementing and scaling up of evidence-based, cost-effective interventions to reduce the risk of these disorders. A UN Convention on the Human Rights of Older People would be pivotal for this, and all governments and policymakers ought to play a critical role in leading and supporting a UN convention. So let's take a little deeper dive into this mental health care issue. Well, globally, mental health care systems have been in crisis for decades, and this has prompted many calls for a revolution in mental health. The COVID-19 tragedy, combined with the societal ageism, has now, for the past 2.5 or 3 years, created a dual pandemic, leading to widespread and devastating impact on older people's lives everywhere. The impact of this pandemic has laid bare decades of discrimination and shortcomings, especially those towards those with mental health conditions. They have resulted in us witnessing agonizing and distressing stories of older people who were previously functioning well, like all of us on the call today, but have succumbed due to the flagrant violations of their rights. Countless reports of suffering due to social isolation, loneliness, precipitous declines in physical and mental health, sharp increases in frailty, concomitant severe changes in cognition, function, and behavior have resulted in paralyzing fear, anxiety, panic, depression, and suicidal behavior. Requests for medical assistance in dying have not been infrequent from these people. And I see this frequently because of where I work in the hospital. The impact on their families of these older people has also been devastating when they watch their loved ones being treated inhumanely, marginalized, neglected, abused, left behind, and often made invisible. This deplorable situation has created an urgent ethical, moral, and legal imperative to establish effective ways to enhance and protect human rights of older people everywhere. Now, I want to take a few minutes and talk about older women in particular. Women comprise a higher proportion of the older population. Women tend to live longer and spend more years of their lives with functional limitations. They also fare poorly compared to men on most indicators of well-being and mental health. Women fare worse than men on a range of other indicators such as personal safety, labor market participation, financial security, housing, and stressors that accompany unpaid care responsibilities. All of these things associated with poor outcomes for mental health and well-being in later life. So age, gender, and mental health intersect once again to produce a perfect storm of inequity and disadvantage for older women. Older women experience poorer mental health outcomes than older men, scoring higher than men on depression, anxiety, and stress, and lower on indicators of well-being and coping. Even among older women and men with severe mental illness, women do poorly on health-related quality of life. Now, women also constitute 2/3 of people who live with dementia. 2 out of 3 people older people are women who have dementia, including Alzheimer's disease. Women are also disproportionately exposed to forms of social disadvantage and health risk that are associated with mental health outcomes. Mental health is therefore an important factor that shapes the gendered contours of inequality and disadvantage in later life. Let's turn to physical health for a moment. We know that as we get older, generally our health changes, and the role of gender in shaping our health and medical outcomes is limited by the lack of emphasis in medicine on gender disaggregated data in preclinical and clinical research. Nonetheless, evidence suggests that age, gender, and mental health once again come together in shaping physical health in later life. People with mental health conditions have a lower life expectancy of 15 to 20 years than the general population, as women are more likely than men to be living with these conditions in later life, including dementia. They're also more likely to experience the impact that the physical health has on their lifespan. In addition, gender-based stigma and discrimination presents limitations to accessing good quality health services in so many countries. Now, the intersectionality between good health with other factors such as economic security, adequate housing, and personal safety are essential for aging with dignity. Older men, and especially women, in both high and low and middle income countries, disproportionately face challenges in accessing these. At these crossroads, living with mental health conditions, their risk of high vulnerability and discrimination is greater, and the lifelong social structures to support and enhance the lives of young girls and women of all ages will benefit them as women get older, providing security and well-being for their physical and mental health. A few words about where people live with mental health conditions, the living environment. There's an urgent need for the development and design for inclusive living for older people with mental health conditions. While most older people wish to age at home, this is not always feasible, and some people require collective or residential living arrangements. There is evidence for positive models that are more home-like, suggesting that this is preferred versus living in big long-term care nursing home settings. But we need further knowledge to look for innovative ways to create care strategies for this. Technology using wearables and sensors or artificial intelligence may enable the freedom, the autonomy, and safety of older people who live with these conditions. Now, we also know that we all die someday. So I want to spend a minute on dying. It goes without saying that bad deaths are bad for not just the dying person, but equally bad for deaths for their families and for the moral distress of their caregivers. The experience of death and dying, especially during the pandemic, for many people with mental health conditions, has constituted not just neglect and abuse, but cruel and degrading treatment has been seen for those people who have died, especially in nursing homes. And I know Margaret Gillis is on the call, and she's spoken about this in amazing terms. Access to palliative care has been curtailed by the demands on our healthcare systems. Support from loved ones restricted and nuanced by advanced care plannings were abandoned in favor of hasty and pragmatic protocols for do not resuscitate orders to triage people. So in conclusion, I offer some overarching recommendations for clinicians, governments, policymakers, NGOs, and others, anyone who cares to listen to me. Number one, mental health for all can be improved through promotion of active and healthy aging and creating environments that allow people to lead a healthy life. Second, promoting mental health must include strategies to ensure that older people have the necessary resources to meet the needs such as safe communities, economic security, and health services. Thirdly, older people, both men and women, should be consulted, and this should be obligatory to shape the policy and creation of healthcare delivery systems. Fourth, access and affordability to healthcare, health information, and the tools to promote healthy aging are critical. Fifth is to integrate in a holistic way models that include physical and mental health, but include palliative care, social and spiritual support, and the needs-based model, and include the living arrangements that we talked about, inclusive living. Number 6, effective and accessible community level, multidisciplinary primary mental health support for older people are crucial if we're going to keep them out of long-term care or hospitals. A shift away from acute care settings of medical and surgical-based care models where people simply go to die now. Most people don't want to die in the hospital, they want to die at home. And this should be supported and encouraged and resourced properly. Finally, I want to say that a human rights-based lens must be applied to every policy and program in healthcare to combat ageism, mentalism, and ableism, and that a UN Convention on the Rights of Older People would go a long way to combating this lens of ageism that is used now to provide care for older people. It would integrate monitoring and enforcement mechanisms, as well as policies and laws to address discrimination, inequality, and protect their human rights. I do thank you all for your attention, and I'm very happy to pass the floor back to you, Eric. Thank you.
Kiran, we could have you talk for an hour because the data that you present, I mean, 2/3 of women will have dementia. Did I hear that right?
Well, I often start my talks by saying this, and some of you have heard me, so forgive me if you've looked to your left and look to your right. And if you have someone sitting next to you, you're very lucky, because the bad news is that 1 out of the 3 of you will have dementia by the time you're 80. The bad news is that the good news is it won't be you. It's whoever is sitting next to you will have it. And people usually start to laugh when I say that, but that is really how we think. It's denial, it's minimization, and we rationalize it. Nothing's going to happen to me. Trust me, I know it will happen to me because I've been through hell for the past year health-wise, so I know it can happen. Anyway, back to you, Erica.
So I just want to, on that note, just have people who I know are just like gobsmacked with all the data that you've presented us. I mean, just so rich. I just want to ask folk to put their questions in the chat because we have Kiran to answer them for us. And I know he's a passionate individual who has not only the expertise, but the will to help us navigate this road ahead to build awareness. So please start putting your questions in the chat. And with that, thank you to Anna and to Holly for your patience, Holly, for all our little glitches. So we are now ready to see Holly's brilliant slides and turn it over to you now, Holly.
So I'm sorry for the delay, and thank you, Kiran, for such a wonderful presentation. Mine is going to be more visual, and I've titled it, "It Takes a Village," because the next slide, please. This is a little awkward, but mental health and aging and global perspectives. I think we think about it, the phrase, "it takes a village," when it comes to children and their development. But what's really important for us to all understand is that it takes a village for all of us to live well and to do well and to remain healthy, strong, and resilient. Next slide, please. This is going to be a personal presentation. This is a photograph of the UN you don't usually see. I took it myself on the way to the UN. There's one train that I can get off in Queens and take a ferry instead of a subway to the UN. And I'm going to share with you not only data, but some of my personal responses and experiences around these issues. I too have had a year of catastrophic health issues, and so it takes one to know one. So I'm speaking from that perspective. Next, please. I think in case there are doubters that there is an enormous impact of globalization on health in terms of every aspect of health. We are, in fact, a small world, and epidemics of non-communicative diseases, rapid spread of pathogens, which we've seen now, increased marketing to worldwide populations, increasing consumption of all these awful things none of us are supposed to have, and tobacco, alcohol, and substance use disorders are increasing among world global populations, and particularly among older adults. Next. This is just a model that I know is complex, but it's what I use to understand. It's Bronfenbretter's model of the ecology of human development, but it just signifies the way in which individuals are affected by their family, their community, and by the policies and ideologies of the larger culture that come back and then shape individual behavior. So we need to have this lens as we look at the experience of aging and some of the risk and prevented protective factors in aging. Next slide, please. So we all know that these are the global goals, and they really, all 17 center around people, prosperity, peace, planet, and partnership. And I'm going to try to present this within this context. I hope it works. Next slide, please. So from the people perspective, we want to end poverty and hunger in all forms and ensure dignity across the range. That involves, from a UN perspective, universal health care, which I'll talk a bit about later on, following up on Kiran's statements, reducing risk factors, promoting healthy lifestyles, promoting health and well-being, and of course, ending discrimination of all kinds. Next slide, please. Some of the ways in which people are affected by mental health has to do with the non-communicable diseases, such as major depression, which, as Kiran said, is expected to be the #1 health burden by 2030. Suicide, alcohol abuse, and dementia. So at the UN, we've begun to talk about NCDs with the same amount of interest and importance as communicable diseases such as malaria and tuberculosis and HIV/AIDS. Next slide, please. We need to have socially and culturally relevant interventions. This is a woman in a village I stayed at in Thailand. She's smoking opium. Clearly, she's addicted to opium, as most of the villages are, but they're not, it's not a problem there. So they don't have electricity. They work in the rice fields during the day. They don't have to steal to get the opium. So we need to have interventions that are not only evidence-based, but really culturally relevant and sensitive. Next slide, please. What we're seeing is a move away from dangerous cultural health practices. This is a young woman with my son in a village on the Thai-Burma border, part of the Long Neck village, they're called. And this we wouldn't consider an exceedingly dangerous practice, but certainly in terms of female genital cutting and other dangerous cultural practices, we need to take a strong view and work with communities, villages, and local populations around reducing the risks. There certainly are many aging Americans in this country, as well as across the globe, who are survivors of cultural dangerous practices. Next slide, please. Some of the health issues, the mental health issues of older adults in the United States and across the world involve very high levels of domestic abuse and violence. Next slide, please. Elder abuse awareness, I'm sure you're all familiar with, that includes neglect, emotional or psychological abuse, physical abuse, sexual abuse, abandonment, and financial or material abuse and exploitation. We could obviously have a whole session about this, but this is a problem that we're quite aware of in the United States, but it really exists throughout the world. Interestingly, part of the Affordable Care Act really involves an Elder Justice Act that has a mechanism for addressing some of these issues. But as civil society advocates, we have to make sure that our local, national, and global leaders recognize this as a real risk in terms of mental health and physical health, and enact some of the policies that are already there, as well as advancing them from a human rights perspective. Next. Certainly, we know that the most vulnerable older adults have been victims of racial, religious, ethnic, and violent hate crimes. And I've listed some of the groups here, not only in the US, where we're extremely aware of this, but really throughout the world, where older adults are being victimized. It used to seem as though younger people were the victims of violent community and street crime, but certainly now older adults are victims. And that generates a feeling of grave fear and trepidation among all citizens, fearing that they might be victims as well, severely impacting on mental health, especially in terms of depression, which we know is a risk factor for dementia. Next slide, please. LGBTQ plus seniors. An interesting phenomenon here in the US is that baby boomers are the first kind of out generation of older adults. By 2030, their number will double. They are no longer considered in the diagnostic manual. However, their experience with stigma and social isolation, as well as violence, bullying, harassment, physical violence, and murder, especially among trans populations, causes great distress among LGBTQ seniors. I was really shocked to learn, this is a 2009 statistic, I haven't seen a newer one, that nearly 50% of the senior centers do not welcome LGBT seniors. And that is just, to me, a huge atrocity. Next slide, please. So part of what we find in the US, but across the world, is that for many aging adults who grew up as I did in the late 60s, I was in college at Boston University and didn't have the opportunity or inclination to do drugs and engage in all those high-risk behaviors. But we now have people for whom my body is not a temple, but an amusement park, and they are feeling the effects of all those years of misuse. And as Kiran said, there's a real inherent responsibility of individuals to take care of themselves and guard for their own mental health and physical health. We also find adults who are very familiar with substances of abuse continuing to abuse substances in older age, as well as medication mismanagement and myriad sequelae of substances and drugs from alcohol and beyond, resulting in mental health issues and problems. Next slide, please. So I love this slide of the global pandemic because for so often you kept hearing we're all in the same boat. It's the first time higher resource, lower resource countries are in the same boat, but we're not. We're in the same turbulent sea, but clearly not the same boat. And that different boats here, you can see, represent areas, countries, regions with differing resources. So we see now, midst the pandemic, post-pandemic, that there are tremendous disparities in rates of vaccination, access to treatment, and a host of all of the other variables that really lead to healthy or unhealthy post-COVID status. Next slide, please. The exposure to human suffering, which Kiran mentioned, I think is really important in terms of older adults who are or have been caregivers, as well as those who have been experiencing human suffering. And there are many issues that follow that: vicarious traumatization, secondary traumatization, compassion fatigue, and burnout, each of which we could spend a whole day talking about. But I think that in our midst, there are many people who are wounded by the exposure to human suffering in person, through the press, and in many different ways. And that seriously affects mental health. Next. Trauma and loss, we all know that as we age, the longer we live, probably the more experience we're going to have with loss. And unfortunately, with trauma also, loss is considered a normal part of living. And there is a healthy grieving process that we can all experience, so that we don't think of grief as pathological. The process involves reminiscing, recollection, and establishing enduring connections with those who are gone. However, if trauma enters into that, it very much complicates the normal, healthy grieving process, because the process and experience of trauma is entirely different. It's activated by the autonomic nervous system in the primitive brain, which creates neurobiological responses that react to intrusive stimuli and try to avoid re-exposure, so that reminiscing and recollection become toxic experiences rather than healing experiences. And certainly among us, we all know our own grief experiences and those that involve trauma and traumatic loss. Next. Next slide, please. So traumatic grief has actually become a diagnosis, and it involves complication of healthy grief for a variety of reasons. Certainly among marginalized individuals without trauma, there is complicated grief often. But trauma, crisis intervention, post-traumatic stress responses affect the normal grieving process. And if they're experienced in youth, as many of our aging colleagues have, then there's an impact on long-term growth and development. So when we think about healthy grieving, certainly there are many among us who have had traumatic losses early on in life, and that stays with you forever without good intervention. Next slide, please. Loneliness. This caption is, it's an aching emptiness millions will recognize. Widowed, her grown-up children busy with their own lives. She says, I never thought I would be so lonely. And certainly, I'm sure you're all familiar with the new data that is very compelling, that identifies loneliness, which might be related to social isolation, as a high risk factor of the magnitude of smoking. So loneliness is defined as the feelings of distress caused by a perceived discrepancy between desired and actual social contact. So that feeling is one that is subjective, and you can't just look and identify who might experience that subjective feeling that would then render them at risk for physical and psychological disturbances. The complexity of this emotional experience can lead to heart disease, malnutrition, poor sleep, cognitive decline, and increased stress hormones, as well as diabetes, arthritis, and weakened immune systems. So if we look at the experience of aging in contemporary society, even without COVID and imposed social isolation, we can really understand the impact that this pandemic has had worldwide, and a threat not only to mental health, but to longevity and mortality. Next slide, please. So if we move on to prosperity, which is ensuring prosperous and fulfilling lives in harmony with nature, we need to have some freedom from poverty, access to reasonable sources of lifelong income. Kiran has mentioned some of this, freedom from excessive medical and healthcare costs, and creating comfortable, healthy life environments that are age-friendly. Next slide. So Kiran mentioned the effect of neighborhoods, and this is really striking because the kinds of neighborhoods that we reside in across the world really vary and have a huge impact on our mental health and our risk factors for disease. Next slide, please. So some of us live in unsafe environments, either due to disasters, community violence, or just danger in the neighborhood. And those experiences have a tremendous impact on our health and mental health, especially in terms of depression and then increased risk for dementia. And there have been some very elegant studies that demonstrate the relationship between fear of going outside and living in the community and the development of multiple symptoms from a mental health and a physical health perspective. And the reason that the impact is so enormous and significant among older adults is because they're more limited in terms of staying in the environment. So it might have been in a neighborhood environment that changed over the years from when they were first living there. And now just the predictable shifts of the community have resulted in a different environment. Or it might be the environmental hazards such as wildfires or air pollution, which is a significant risk factor, as well as noise pollution, other kinds of pollutants, water, and all of those. Next slide, please. Some people live in neighborhoods that are remote, like this village in Thailand, where there are wonderful opportunities for water and clean air. However, the demographic trend is that young people are leaving and moving to urban environments, to cities, which leaves some people really isolated and without the children they expected to care for them as adults, and also with very limited access to healthcare and the other resources that are so important for mental health. Next slide, please. And of course, the shifts away from, this is a multi-generational family living in one room in also Thailand. These were people I stayed with years ago. And not everyone has access anymore to this multi-dimensional living situation. I grew up down the street from my grandparents and in very close proximity to my extended family, none of whom live near me anymore. And most of us need to rely on others rather than kin in order to decrease social isolation, but also enhance our resources to the kinds of things that we really need. These are all attributable to neighborhoods and where we live. Next slide, please. I found this fascinating. We're very aware of green space and how important in a positive way it is to live near trees and other green environments. But it's recently been identified that blue space or access to water is an extreme variable in health and well-being. So one study in particular in Scotland associated the access to blue space, which is the proximity of water, either having a view of the water or being close to the water, and its relationship to the number of antidepressant prescriptions. And a very clear relationship was found, not only in access to blue space, but in a dose-related relationship between the proximity, the closer you are to engaging with blue space, and the decreased number of antidepressant prescriptions. So it's really interesting to me and really challenging how we can introduce this environmental protective aspect in urban areas and situations where it doesn't exist. Next slide. And I'm thinking in terms of, I'm working with a local program for adults with dementia, and we're arranging to have an aquarium in the center so that we actually live near the water but don't have access to it, but where people can at least experience some of that blue space. The next global goal is peace. Certainly we're all familiar with that, and that's what brings many of us to the UN. Next slide, please. But we certainly know that peace is not simply the absence of war. And this is just a card that I've always liked. It doesn't mean to be in a place where there's no noise, trouble, or hard work. It means to be in the midst of those things and still be calm in your heart. So as advocates, what we can do that's so important is that in the midst of the kinds of social and geopolitical turmoil is to help individuals and communities create a sense of peace within them. Next slide, please. And to try and bring some of this feeling, this was, by the way, in Uganda, at a time when I was working with former child soldiers who did not have peace in their heart, but the idea of trying to introduce this kind of external calm and peace into our internal lives. Next slide, please. One of the things that's affecting the mental health of millions of individuals, we really don't think about this, are survivors of war in many different ways. And an issue that I've been very interested in, because I've adopted a family who was caught up in this, are war babies, so that there are tens of thousands of children born during conflict as the result of rape. Not individual rape, but gang rapes and sexual exploitation that are used as a political strategy of war. And these children and their mothers living all over the world right now are aging and are deeply affected by the social upheavals that brought about their conception, but also by their treatment by society, the society in which they live, and stigma regarding their biological origins and traumas of their mothers. Next slide, please. This is so striking that this rape as a strategy or instrument of war has been implemented for centuries. In the Bible, there are descriptions of rape as a strategy, circumstance, or outcome of war. It's not a new phenomenon, although we tend to think of Boko Haram and some of the newer issues, but there were mass campaigns of rape and sexual exploitation during times of war in almost every continent, North America, Australia, Europe, Asia, Africa, in countries that were invaded or had military and militias. The Korean comfort women are aging now. There are age in terms of older adults, both here in the United States, in China, in Korea. And the comfort women was a strategy employed by Japanese after extensive rape and killing of Chinese. And they wanted to somehow slow down the rape of this massive rape of women, and also escape the publicity surrounding widespread rape. And but they wanted the soldiers to have the opportunity to continue to rape women, so that women were abducted. Some of them, as in human trafficking now, were told that they would have an education or a job, and they were sexual slaves for many years. Those women children and adolescents are now still alive and suffering with that long-term history of violence. And certainly we know that there's historical and institutional histories of this kind of violence, and we're especially noticing it now in the United States and Australia and among indigenous populations in Canada and other areas in North America. Next slide, please. Many individuals are living under the shadow of terrorism, and terrorism is not dependent on the numbers killed as much as changing the fabric and spirit of the community, so that the goal is to traumatize and immobilize populations with threats and physical destruction, killing, and the survivors are forced to witness catastrophic injury, and the sense of horror and vulnerability lasts a lifetime. And unfortunately, that's occurring right now in our midst. And so we have survivors who are walking around with this kind of trauma, both in the US and across the globe. Next slide, please. So now we move on to the planet. And that's something that we're probably all so familiar with, but protecting the planet's natural resources includes access to safe surroundings and the free use of land, access to clean water and sanitation, access to comfortable climates and sustainability, and freedom from natural and human-made disasters. And there are excellent studies that demonstrate the mental health effects of climate change, whether it's excessive temperature change or storms or the loss of land due to changing topography. Next slide, please. So, and the next slide also, we know these faces, next slide, of human misery in response to these catastrophic climate events. But now we come to the last area, which is partnerships. And I think this is where we have some optimism and possibilities for making all of this suffering and these long-term damages to mental health in ways that, as Kiran said, are invisible and not so obvious, we can really improve. And that's developing global partnerships with policy and decision makers. We do that at the UN. Having intersectional, interdisciplinary partners so that we're not siloed within our own discipline or area, and that academic clinical research and, most important, grassroots advocates are involved collectively in the process of policy development. And as Kiran said, no population should be left out. Civil society and multilateral partnerships, another area that we engage in at the UN, and really looking at local to global private-public partnerships. So what can we actually do to make this a better picture? Next. So we can't direct the wind, but we can adjust the sails. And I think this is something that I live with all the time. Next slide, please. And the idea of our meeting today and what we do really at the UN is form a social network, and our connections transcend individuals and our own limits. And the model always that's meaningful for me is that brains can accomplish what no single cell can do. So whenever I feel personally overwhelmed or saddened by what's going on, I turn to an activity like this that really lifts my spirits and makes change seem much more possible. Next slide. Certainly one area to enhance mental health is violence prevention in every way at the individual, family, community, local, regional, and global levels. Next slide, please. Let's skip this one. We have at the UN these ways of acknowledging universal health care is something that everyone at the UN made a commitment to, every member state, and addressing areas of quality health services with all of these aspects is crucial. Next slide, please. And that involves really investing in people-centered healthcare systems, which strengthen the healthcare workforce. Next slide. The problem with internet quotes is that you can't always depend on their accuracy. Abraham Lincoln. You'd be surprised how many people say, did he really say that? Well, no, of course he didn't. But one of the things that we can do within the UN system, especially through UNESCO, is have valid sources of verified information. And the program called Verified from UNESCO is really important in disseminating reliable information and also teaching all of us how we can have accurate facts rather than just accepting whatever's on the internet. Next slide, please. Certainly, peaceful methods of coexistence are important. Next slide. I hope this one isn't inappropriate. Tell me, Edna, did you and Earl ever have mutual orgasm? And she says, no, I think we had State Farm. So having a common vocabulary and a common notion of terms, practices, and policies is really important. Next slide. And these next slides just deal with the whole internet thing. What does IDKLY and TTYL mean?
Yeah.
And I'm encouraging all of us to regard ourselves as vulnerable, and we need compassionate self-care. Continue, Anna. When you're over the hill, you pick up speed. Always wanted to see the positive. She uses for hot flashes to heat her coffee. Next slide. This has to do with the neuroscience of altruism and the way in which we feel we're protected because of our altruism that really helps our mental health. The world breaks everyone, and after some are strong at the broken places. One's mind, once stretched by a new idea, never again retains its original dimension, another justification for what we do. I close every presentation with this slide. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. I had an opportunity to see Margaret Mead when I was in college. Next slide. I think this is the last. So here's some of what we can do as civil society. Accelerate the national implementation of SDGs. Hold the partners accountable for the commitments that they all made, because they made these commitments, and to learn more about the goals and how all of us can contribute. And the final slide is a sense of urgency. I think so many of us think, all right, tomorrow, I'm tired today, but there is a sense of urgency about all of this. Thank you, and I'm sorry for the delay.
No need to apologize. I just wanted to get to the questions because we're coming close to the wire here on time. I'm going to start off, Kiran. There were a couple of questions for you, and then I'll turn over to Holly. These are from the audience, and then I have a couple of my own. First question is from Marion. Could you speak to how depression is a risk factor for dementia? I think, we talk about it, but what exactly, how is it a risk factor? Anne asked the question of, could you speak to and Holly just brought up universal health coverage. So maybe this is for you too, Holly, to think about. Mental health in the context of universal health coverage. How do we get it in there, and how can the issue be really elevated? I mean, one of the things you talked about, Kiran, right up front were political determinants. So I'm just putting that out there. Cynthia Stewart says there's a book by Becca Levy called Age Code that says positive attitudes toward, and Kiran, you talked about self-ageism, yeah, and the negative impacts of that. But here is a book that's come out that talks about the positive aspects of positive attitudes toward aging can increase longevity by 7.5 years. Now, if that is out there, how then can we dispel these ageist attitudes? And you did say the hardest one is self-ageism and having self-ageist notions. Okay, so again to Kiran, and then Holly, I have mine for you. You talked about economic disparities, you talked about health disparities. So I'd like to raise with you the cost, if you have a number, of ageism. If we were to talk to governments about what ageism in their policies, whether it be in workforce, whether it be in health, well, in this case, in health, what would that number be? All right, in terms of mental health. I'll leave it there. Maybe you can start answering while I get my questions sorted for Holly now.
Okay, thank you very much, Erica, and thank you, Holly. I really enjoyed your presentation as well. I appreciated the different lenses that you put on it. So I'm going to start with the last questions first, Erica, if you don't mind. And I want to acknowledge Becca Levy for some of this work and Chang for the other piece of work. So the health consequences of ageism, there was a very comprehensive review of this meta-analysis published in 2020 with 7 million participants, which demonstrated that 95% of the studies that they included in this meta-analysis showed a very strong association between mental health consequences of ageism, particularly depression, which was the most negatively affected in over 6 million people when they were subjected to ageism. I also want to address the economic impact, which was published in 2018, which considered the impact of discrimination aimed at older people, negative age stereotypes, and negative self-perceptions, which you talked about with Becca Levy's paper, in people over the age of 60 as predictors of ageism in the US. And it estimated that the 1 year cost in the US alone was $63 billion, with a B. Now, the good news is that they predict that if you can lower ageism, it would improve not only the financial cost, but also the health costs might be reduced. So those are my responses to those two questions. I'm going to let Holly talk about the universal healthcare. I'll just finish with a quick response to the depression being a harbinger of dementia question. There's a long answer to that, but I'll give you the quicker one because of time pressure. If you look at the older population who have depression, and so there's a late onset depression versus early onset. Those people who've never been depressed in younger life, but develop depression in old age, there's a good percentage of them who have what we call the amnestic footprint, where in other words, they actually start to have cognitive problems as part of the depression. When you treat their depression, some people get completely well and the amnesia, the cognitive portion actually resolves, but in a good percentage of them, it doesn't. And they go on then to develop dementia. About 30% of people will do that, not 100%. And those numbers are different depending on which studies you read. So it is a harbinger if you have the amnestic footprint in we call it MCI, or mild cognitive impairment, but there is different types of MCI. There is an amnestic version, which actually has a higher rate of conversion to dementia. I'll leave it at that.
Wow, Kiran, I really feel like I need another degree. I want to study brain health now. This is just fascinating, the data that we're hearing today.
It's the final frontier, Erica. The brain is, yeah.
Really, Holly, I have a bunch of questions for you too. I'm going to do the same like I did with Kiran. Thank you for your answers. I hope it helped our audience who had the questions. This is a question because you started your presentation by talking about the linkages with the SDGs, yeah? Mm-hmm. So Cynthia wants to know, how can we ensure that the data are disaggregated by age and sex and sexual orientation across the lifespan when we're talking about SDGs, the intersectionality. In this conversation, we've talked about women. SDG 5, gender, is an area that we struggle with because older women are sort of invisible. Then also when you were talking about trauma, and I had my questions all lined up, you talked about traumatic grief. Could you comment for us on trauma and older adults? What about issues such as post-traumatic stress disorder, and what sort of responses there might be among this population? You talked about marginalized groups, and thank you so much for all those visuals and bringing in the whole cultural aspect on, how complex this issue is using a cultural lens. Which brings me to the question about in the United States, for instance, we are a country of immigrants, and we have a global issue right now around refugees and conflict. What do you perceive as some of the ramifications on mental health and migration, if you will, for older persons? Oftentimes we've seen in issues of migration, older persons are left behind, and we see that also in conflict. But also sometimes we have older persons who are forced to leave. You talk about it at the local level, you talked about neighborhoods, right? And you talked about disasters. But on the global level, how do you address the mental health of older persons who have had to not only leave their local area, but flee their countries? I mean, we have on our meeting today, Olena from the Ukraine, and my heart goes out to you on behalf of all of us at this meeting today, Olena, about what's going on in your country. Right now, this is real as we speak. So I want to raise that one with you. And we started our meeting with talking about May being Mental Health Month, also Older Americans Month. June is Pride Month. Now, we do know we've had programs in the past where we've talked about the older LGBTQ community. And when they were in nursing homes, sometimes the older gay populations have had to go back into the closet due to the violence and abuse that they have felt within these nursing homes just because of their sexual identity. I'll stop there and I'll give you the floor. Sorry for throwing it all at you.
Questions, and I think talking about mental health really is very complex with so much intersectionality. So some areas really involve what we call primary prevention. And certainly the education about ageism, about prejudice of all sorts involves in trying to prevent some of this from happening. And that means educating large groups of individuals, and particularly caregivers, administrators of these facilities, but also community leaders. And as we see more community leaders who are gay themselves or involved in long-term marital relationships, creating new kinds of families, the more that's discussed rather than hidden, I think it will. And I think personally, that's what's resulted in so many of the legislative issues we see changing here in the US, but also across the world, because there are countries where homosexuality is punishable by death. But I think that the clamor that has occurred here in terms of understanding that this is not an illness, it's not pathological, has resulted in enormous change, which is unusual. And there are some areas in the world, Israel, that's considered the gay capital of the world in many ways. So talking about it and publicizing it, I think is really important. However, in this climate of increased violence, we see increasing vulnerability of gay and trans folks, especially Black and African American trans women, so that there is a real sense of danger, life-threatening danger. And it's important that we not only have primary prevention, but secondary prevention, so that we educate law enforcement, community service agencies, senior citizen centers that are designated with the responsibility of providing service. And yet in 2009, they were withholding it from people just because they were gay. So I think that's important. We're going to have a meeting in June, the Committee on Mental Health, that we'll tell you about, that's focusing on LGBT issues. But back to neighborhoods and housing, that is a major issue for older LGBT folks, because they don't feel safe unless that many of them in an environment where many of the people share their identity. And so there are housing developments arising and areas where they can feel safe in themselves. However, we'll get back to policy and financing, and that's an issue, but I invite you to join us. But I think we need to be aware that the needs of older populations, LGBT, are different than young people who are coming out in the context of great social and increasingly familial support. In terms of the refugee and immigration issues, one of the things that I heard early on in my private practice, the clinical work I do, is that among older adults here in this country, Afghanistan, the Ukraine, it was really reviving their own experiences of immigration. So one thing we have is being forced to leave your country because it's endangered. However, the journey itself often entails grave danger, physical danger, as well as the sexual exploitation and assault. And from a perspective of post-traumatic stress, that often stays with an individual and manifests in many different ways. Now, we first began to understand PTSD in the context of Vietnam War veterans. And then we moved to adults, and now we're very sensitive. Lenore Terr in the early years talked about children, but we really haven't looked at older adults who have carried with them the scars of trauma, abuse, neglect, and worse. And so we need to take a look at that and really begin to understand it. But the process of the traumatic response is not what we consider psychological, whatever that means, but it really is neurobiological. So it's in the biology. And for those people who suffer with those symptoms, it really needs to be addressed. And I think older adults we haven't looked at, although their burden of trauma is much greater. And I think that we at the UN need to keep asking loudly for disaggregated data of every kind, whether it's children or adults. And it's up to us as the advocates, I think, to continue to ask for it and press NGOs to ask for this data, and also better ways of measurement, because for some of the things we're talking about, we haven't really established good measurement. Therefore, we can't use the data as well as we'd like to.
Yeah, well, I'm so sorry, but we have to, sorry.
Erica, can I just add one quick comment to what Holly said? Just in terms of trauma and PTSD, and this is of interest to a lot of people, I'm sure. When a younger person has gone through trauma,
Yeah.
I'm talking severe trauma, but they've dealt very nicely with it. They've got the resilience. But when they develop dementia later on, that trauma comes out. And we see it a lot. And people don't think about that because it happened so long ago. But it surfaces because the top 2 or 3 layers of the memory are gone. But what's left is what was there before. So it starts to emerge. Anyway, you have
And
to deal with that. It's
that's
really
the
interesting.
experience of danger and threat. So it's not a cognitive memory, but this feeling of vulnerability and terrible fear and helplessness. And it's so sad and heart-wrenching. Yeah.
Sorry, Erica.
No. I mean, this is why I said this conversation could go on for a few hours, because there's so much to unpack here. And I know our audience is fascinated because very few people have actually left us. So I want to thank everybody for their patience, but most of all, really, Holly and Kiran, absolutely brilliant session. And, you know, it's a lot. We got to work on this together, as you say. And if you can just post that quote about the mind, which you started with, because I absolutely loved it. And of course, I'm not going to take up any more time. So thank you. It was a pleasure to moderate this event. And I turn it over now to Francis.
Hi, thank you so much, Kiran and Holly, for your presentations. There was so much for us to absorb, and as Erica said, you know, very few people have left, and it's been an amazing eye-opener. And we've learned that, you know, while many factors have can affect mental health, whether it's medical problems, bereavement, financial situation, mental health conditions can also have an impact on an older person's ability to carry out basic activities of everyday life. We have learned again that ageism continues to rear its ugly head. It is clear that there's a constant battle to ensure that older persons are not discriminated against on the basis of age. And we must be constantly vigilant in calling out age discrimination. Where do we go from here? And what do we do with all of this information? Many of us in attending this meeting are interested in what is happening about older persons' issues at the global level and what we can learn from other countries, what we want to happen to improve the lives of older persons, and what can be done to ensure that they lead a life of dignity. I would like to suggest 3 immediate actions that can be taken so that we can make use of what we've learned today and take it one step further to work towards policy change to improve the lives of older persons everywhere, irrespective of their economic and social situation. These are very, very simple steps. We want everyone to join the NGO Committee on Aging, and Anna's going to put our website there. That's number 1. We want everyone to join the Committee on Mental Health in its efforts to promote psychosocial well-being. And the third one is to join the Global Alliance for the Rights of Older People. And the website is going to be in the chat as well. It is important to do good work to help older persons, but it's not enough. We need to change, strengthen, and improve policy to ensure that their rights are protected. So while we're all here wondering what we can do, we must as well need to advocate for an international legal instrument to protect the rights of older persons. So I hope everyone will join us in that effort. And we look forward to everyone participating in the various events of these 3 key organizations. And I want to thank everybody for attending. And I'd like now to give the floor to Cynthia, who has a few of the last words.
Oh, I was just going to say thank you to Francis, the chairs the program committee, subcommittee, for this wonderful program, and for all of our speakers. And I think your action steps are perfect. So thank you all for being with us. Good day.
Thank you.
Bye. Thanks. Bye, Francis, Cynthia, Erica, Holly.
Okay.
Take care. Bye-bye.
Thank you, Kiran and
Bye.
Holly. Bye.
And moderator, you were fabulous.
Awesome.
Yeah,
Yeah.
Erica's always so good.
Anna, thank you. Yeah.
And Anna behind the scenes. All good. Thank you.
Bye.